Welcome to Risk Adjustment Documentation and Coding for Providers. Today's topic, Rheumatologic Diseases. There are many rheumatologic conditions that are relevant to the risk adjustment model. Almost all of the diagnoses have the same coefficient, but we will review 3 scenarios where using a more specific diagnosis code can increase the coefficient. Rheumatologic or autoimmune diseases can be present for years, but you should document and code these conditions even if they are stable or well controlled. It is important to document and code these conditions at least once in a calendar year. However, if a condition has resolved, then the diagnosis should not be included on the claim. Documentation must show evidence of MEET, that you have monitored, evaluated, assessed, or treated the condition. And to be included in the risk score, the diagnosis must appear on a claim. Today, we will discuss common rheumatologic conditions that are applicable to the CMS HCC risk adjustment model. There are nearly 900 rheumatologic diagnosis codes included in the risk adjustment model, and most of them have the same coefficient. As you can see in the table below, common conditions such as rheumatoid arthritis, lupus, polymyalgia rheumatica, or sickle syndrome all have the same coefficient of 0.374. However, arthritis secondary to infection will have a higher coefficient, so for situations such as arthritis due to Lyme disease or reactive arthropathy, the coefficient is higher at 0.498. The second scenario to review is when you have a rheumatologic disorder with lung involvement. ICD-10 provides specific diagnosis codes for rheumatologic diseases with lung involvement. Almost all of these conditions will contribute 2 HCC categories, or 2 coefficients, to the risk score, with the exception being rheumatoid arthritis. As you can see in the table below, rheumatoid lung disease with rheumatoid arthritis of an unspecified site will yield a single coefficient of 0.374. However, if you have lung involvement in systemic lupus, you will get 2 coefficients for that single code of 0.374 plus 0.274. You will get 2 coefficients if you have lung involvement with either lupus, polymyositis, dermatopolymyositis, systemic sclerosis, or sickle syndrome. The third scenario is when you have neuropathy present with either rheumatoid arthritis or systemic sclerosis. ICD-10 again provides for specific diagnosis codes that will contribute 2 HCC categories or 2 coefficients if neuropathy is present with either rheumatoid arthritis or systemic sclerosis. So looking at the table, you will see that rheumatoid arthritis with rheumatoid factor unspecified has only a single coefficient of 0.374. However, if you have rheumatoid polyneuropathy with rheumatoid arthritis of an unspecified or specified site, you will get 2 coefficients, 0.374 plus 0.408. This is also true for systemic sclerosis with polyneuropathy. You will again get 2 coefficients. So this is another scenario where a more specific diagnosis code will yield a higher weighted coefficient. In summary, most rheumatologic diseases are in the same HCC category, but we reviewed 3 scenarios where specific documentation will lead to a higher weighted coefficient. It is appropriate to document and code all clinically relevant active and chronic conditions that impact the care of your patient, but your documentation must show MEET, that you have monitored, evaluated, assessed, or treated the condition. Do not code conditions that were previously treated and no longer exist, and documentation in the assessment and plan is preferred. Finally, ensure that all relevant diagnoses are documented and put on a claim at least once in a calendar year. Thank you very much for listening.